Hello, everyone. This is Deb Anderson with Mountain Pacific Quality Health. Thank you for joining our webinar today. Today we are actually doing a regional event, so it doesn't include just our wonderful Wyoming folks, but also others within our region. That would be Montana, Alaska, Hawaii, and Pacific Territories. Today we are going to talk about how the chronic care prevention work helps improve quality scores across the board. I'll be joined in the presentation by Zack and Sharon and Randy. So we will introduce each of them as we get to the slides that they're presenting. I did want to let you know that the presentation is being recorded today and that the information in the slides will be shared with all of the registered folks when the recording is reviewed and made available. All right, a little bit about Mountain Pacific. We are a collaborative, part of the National Quality Improvement Organization Network. We are operated locally. We have a Casper office. We also have offices in each of our other states as well to help improve healthcare by supporting the providers, the practitioners, the patients, and our stakeholders. We provide solutions. Our solutions are to help achieve better care, better population health, and to lower healthcare quality costs through quality improvement. We are a nonprofit and we help with all of our other partners, including folks like the Office of Rural Health, Flex Grant recipients, and the State Departments of Health. We also have some private contracts that we do as well and get our funding from other funding sources. Our goals for today is to talk about aligning your quality improvement efforts. Basically, this is the bang for the buck that we talk about all the time. And, you know, instead of having those pages and pages of required measures or all of the different organizations asking you for measure after measure after measure, this is how we would help you go through and prioritize what your quality improvement programs could look like, and hoping to help you keep focus and reduce the burden for reporting for your organizations. We also have a little bit of information from Zack on patient-centered medical home. And then Sharon Phelps, our subject matter expert on MIPS, the merit-based incentive payment system, will give you lots of information about how the great work that you do already can help improve all of your quality scores. And then I'll finish off with just a few updates today. So this is me. Most of you know me already, but if you're joining from other regions, maybe not. I am Deb Anderson. I have been with Mountain Pacific Quality Health for 6.5 years now. I started when we were the Regional Extension Center. I have 35 years in information technology experience and 18 in health IT. I like a lot of the health IT changes. However, I know that a lot of them have been very challenging for many of our providers and our practices. So hopefully through our experience of supporting the hospitals and physician practices, we can help you with trying to keep it simple and continuing to move forward in the new payment models, as well as promoting interoperability of healthcare information across the nation. And for our rural frontier folks, I was born and raised on a farm in the middle of nowhere, Nebraska. So today I'm going to talk a little bit about aligning the QI efforts, why the quality improvement is important as we move forward, what tools are currently available to help you, and how alignment can help create focus within your organization and reduce burden within your organization. So please remember that we want this to be interactive, and we do have probably few enough number of folks that we could unmute the telephones, but you can also raise your hand or put a question in the chat box and we'll get that addressed as soon as we can. All right. I'm hoping that most of you have heard about pay for performance. So basically this is the transition or transformation of healthcare payment models to accurately reflect and pay on the specific focus of delivering quality and safe care, instead of trying to have that lovely little mill where we get to bill for all the number of patients that we see. Instead, you get to be paid upon the value that is provided to each of those patients that you work with. So it is designed to spur efficiency and reduce unnecessary spending. That's where some of the telehealth and the promoting interoperability pieces come into play as well. And we've talked about that previously, but we're happy to answer questions on those at any time. And again, the payment model will be based upon showing the quality care that you are providing. And chronic care management is an incredible way to make sure that we aren't losing patients through the cracks. We're helping to control costs, and we're able to report the quality data because our caregivers are paying a lot of attention to how the information is being recorded in the EHRs and getting reported appropriately. So most of you are using Certified Electronic Health Record Technology. We call that CERT. I know it's just another acronym for our alphabet soup mix, but this is basically those EHRs that were required by CMS in order to get incentive funding from meaningful use, and the program is now called Promoting Interoperability. But that is the tool that we want to help you use to the best of its ability. There were certain certification criteria for each level of meaningful use, the stage 1, stage 2, stage 3, and in those standards are specific tools or specific resources that are to help us as we move forward with working on our specific population health improvements. So examples of that would be a patient list by condition or diagnosis, creating patient panels, a panel for all of your diabetes patients, a panel for pre-diabetes folks that are predisposed or maybe have taken the screening tests and are showing moderate risks, patients who are missing their A1Cs, and then also maybe the high-risk populations and how we would be able to screen those populations to determine when there may be some appropriate interventions to work on, including self-monitoring of blood pressures. Also, health information exchange. As you saw on my introductory screen, and I didn't touch on it, I am quite involved in health information exchange in both Wyoming and Montana, and I'm happy to try to answer questions around health information exchange and the ultimate goal of being able to pull community health records or aggregated data on our patients down into our electronic health records to help us have more complete data and also tools for population health analytics. And then some of you have heard us talk about clinical quality improvement, and electronic clinical quality improvement is basically the same process, but we're trying to help you efficiently use your electronic health records to make improvements basically in reporting, not only providing and implementing best practices, but also making sure that you're reporting your quality care that you're providing to the patients, and also hopefully enhance the patient experience and appropriate resource use. And again, resource use would be trying to avoid duplication of lab tests, radiology tests, anything that helps us keep the costs down and the patients from being frustrated from having to repeat things time and time again across different healthcare settings. So the important thing that we want to share with you is that while there are tons and tons and tons of quality metrics and measures available, we really would like to help you keep it simple. So when we start doing the alignment assessments with you, the first priority would be to know what programs that you're in and what is your required quality reporting for your organization. And then within those required programs, what are the measures that are required to report? Number 2 is look at your optional programs, like an 1815, or look at your high needs populations or your geographies, because when you find the right patient group to focus on, you will increase patient satisfaction, you'll probably decrease costs, and I think it'll also help your provider and your staff satisfaction. So here is a quality measure crosswalk. And there are several programs that are out there that, again, are asking for data to be reported. Let's use that diabetes A1C poor control measure. There's different measure numbers given with it under different programs, but we know that it is required, or it applies to PCMH, it applies to MIPS reporting, it applies to our CPC reporting clinics, it also applies to the FQHCs under the UDS reporting, and then also GIPRA, which would be one of the government reporting requirements for folks like IHS. So as you can see, there's several of the top three are the quality measures that we're asking you to report under 1815 for Wyoming, and then also closing the referral loop is going to be very important as we start tracking our referrals and showing that we can make improvement on the number of patients that we're getting referred to lifestyle change management programs or diabetic educators, or even having them do the self-monitoring of blood pressures. All right, so here is the 1815 project measures. These are specific to Wyoming. I think they cross over into Montana and to Hawaii as well. Some of those programs have some additional reporting requirements. But again, the goals for us are also to engage the non-physician team members in clinical settings to be part of the care team. That includes our MAs, any of the folks that work with the patients, calling to help them schedule annual wellness visits, schedule their lab tests. So there's a lot of folks that spend a lot of time supporting our patients, and we want to make sure that we are able to count them as an important part of that care team. We will also be facilitating self-monitored, self-measured blood pressure monitoring in Wyoming specifically. We have a few pilot projects that have been underway and have some best practices, but hope to identify several more before the end of our contracts. And then there is a referral tracking to the approved CDC programs, and those would be like a DPP program, some online lifestyle change programs, registered dietitians, and certified diabetic educators. All right, so that is the end of my lovely to-do list. So at this point in time, I'd really like to introduce Zack, and Zack is with Lander Medical Clinic. He is a graduate of the University of Wyoming in 2018 with his bachelor's in finance. He is a Wyoming resident for the last 14 years, and we're excited to have him with us today. So Zack, I'm going to go ahead and forward the slide and let you go ahead and get started.
Thank you, Deb. This year, our clinic has focused greatly on improving our chronic care management, or CCM. And the way that we've been doing this is by running monthly reports in our EHR system, which help us identify patients to potentially enroll in the program. Eligible patients for this are those with 2 or more chronic conditions, which is required by CCM. And we have also designated specific staff members for our chronic care management team. And the goals of the CCM team help to satisfy guidelines for quality programs such as MIPS and PCMH as well. An example of this is that the CCM team works to ensure that patients are up to date on various cancer screenings, as well as their annual wellness and other things as well. In addition, we have been doing monthly reports on quality measures for MIPS and PCMH. And with these, we are able to identify areas that we need to improve on and determine which measures we need to focus on, and then communicate that to our clinical staff. In addition, we do have quarterly meetings with the Wyoming Department of Health. They give us an overview of all these quality measures, which are, and they also give us information on gaps in care, which is based on our claim submission data. And with that, that includes information on measures such as adolescent vaccinations, as well as diabetic care and other measures as well. Next slide, please. So our clinic receives PCMH accreditation from the National Committee of Quality Assurance, or NCQA. And part of the requirements for the NCQA is that they require us to do chart reviews on an annual basis. A large part of this is related to care planning. You can see on the slide here the questions that are pertaining to that. And our CCM team actively works to have all of our CCM patients work through all of these care planning questions. Originally, before we had the CCM team doing this, it was a burden for us to actually meet these requirements. But now with their help, it has become much easier to accomplish that. Next slide. So in conclusion, our CCM team has helped to increase communication between patients and staff members. All of our CCM enrolled patients are assigned to a specific team member, which helps to better assess the needs of each patient on an individual level. And because the individual is assigned to one team member, this actually ensures that the patient's healthcare is documented more accurately in our EHR. One of the largest issues that our clinic has had with MIPS and other quality measures is having the proper documentation in our charts in order to meet these requirements. And with these team members assigned to these individual patients, it does help to ensure that we do document everything correctly and are able to get credit for all of those quality measures. And then finally, by doing the monthly reports on these measures, our clinical and quality teams can address the areas that need attention and then develop a plan and work to improve them throughout the year. Does anybody have any questions on that?
Hey, Zach, this is Deb. You had indicated that you meet with the Wyoming Department of Health, but I think that's specific to the Medicaid department, the folks in Medicaid?
Yes, that is what I meant.
That's okay. And they're the ones who are paying you the PCMH per month per member reimbursements, correct?
Yeah, that's correct. So on a quarterly basis, they'll send out the information and we can bill that per patient that is enrolled or has Medicaid, and we are considered the patient-centered medical home for.
All right, thank you. And Mary is getting all excited for me, and she's launching the poll for Sharon. I see it on my screen. In preparation for Sharon to provide you with great information, if you wouldn't mind taking the poll that you're seeing on your screen right now. It's talking about the status of the clinicians in your organization and if you know what their MIPS status is this year. So we're going to give you 30 seconds to finish that poll. And I'm going to introduce Sharon, but obviously she's got some great credentials that are already showing up on the screen. But for me, it's the knowing Sharon for many, many years and sharing my little update bio information and realizing that we still have so much in common, although she's the nurse and I am not. So all clinical questions I will always direct to Sharon. So Sharon, do you have any other questions, or please go ahead and get started for us.
Thank you, Deb. I am enjoying seeing the results in the poll. Not surprisingly, all three areas are showing people indicating all of those statuses regarding MIPS. So thank you, Deb, for the opportunity to speak to your group today. I am going to talk about your work with care coordination and the 1815 program and how that aligns with MIPS. In fact, CMS really designed MIPS to take advantage of your existing activities and priorities to be the basis of your MIPS reporting strategy. You should be able to build your MIPS program off what you are already doing, off those priorities you have identified for your clinic, for your patient population, for other reporting programs, and you should just be able to launch from there. So today I'm going to give you a brief overview of MIPS as some things have changed for 2020, and then I'm going to talk about alignment opportunities. The MIPS program has a vast number of details and aspects, so there's no way I'm going to attempt to cover all of those today because that takes me a little longer than the time I've been allotted. But what I'm going to do is I'm going to talk about what's coming in 2020. And if you have any questions on MIPS that I don't cover, please feel free to put that in the chat, or you can go ahead and contact Deb or Brandy afterwards, and they can certainly make sure that I get those questions and I will help get those answered. We have a lot of resources. CMS has a lot of resources, and we can get you tapped into those. So for 2020, this is the 4th performance year for MIPS. Each year of the program, CMS has gradually increased the neutral benchmark at which you have to get a score or you will get a negative adjustment. They have also increased the negative adjustment every year. At the same time, they have changed the weights of the 4 categories in MIPS so that the weight adds up to a final score of 100 if you capture all the points within each subcategory. There's 4 subcategories: quality, advancing care information, which is the use of your EHR that Deb talked about, improvement activities, and cost. We were expecting CMS would move the quality data to 40% and the cost data to 20% this year, but they did not do that when the final rule came out. Cost is still at 15%. And they did that because people are still getting used to that cost category. So we're going to talk about that in a little bit. But that's one of the surprises we found in the final rule. It's important to note in 2020, you now have to have 45 points or a score of 45 in order to avoid negative payment adjustment for the 2020 performance year. The payment year for the 2020 performance year will be 2022. So that 45 points means you have to report pretty much either in the advancing care information category or in the quality category. You have to get points there or you're not going to be able to hit that 45. The quality category is still heavier weighted. So if you're going to put your focus somewhere, put it on the quality category. Additionally, if you are a small clinic, you can take the hardship for the advancing care information section, and you don't even have to worry about that one, even if you have an EHR. It's really up to you, and we can help walk you through that if you need. But the place to really focus your efforts is on quality. Next slide, please, Deb. There are, just like last year, you need to report on 6 quality measures for the quality category, and at least one of those needs to be an outcome or a high priority. If you report on 3 measures that are outcome or high priority, you can get additional bonus points for doing that, and I'll talk about that in a bit. But what has changed in the quality category for 2020 is you now must report at least 70% of the eligible cases for any given measure. So for example, if you are doing the hemoglobin A1C measure, you need to report on at least 70 of the patients to whom that measure pertains in order for you to meet one step of the data completeness. If you are a small clinic, you get 3 points if you don't meet data completeness. If you are a large clinic, which is 16 or more providers, you would only get 1 point if you don't meet data completeness. So that's becoming increasingly important to be aware of that standard and how to meet that. So that's an important change. Okay, next slide, please, Deb. Okay, CMS, as we saw from the previous slide, they are really trying to increase focus on outcome measures, and over time they are slowly moving out what they see as low value process measures. Process measures are easier to improve on because everything you need to do is within your clinic. Whereas an outcome measure, that really is based on what the patient outcomes are, like what is their hemoglobin A1C or what is their blood pressure. Those are a lot harder to move, but they also are a better indication of quality and positive patient outcome than a process measure. So as it pertains to the list of measures for 1815 that Deb showed earlier, what we see is that hemoglobin A1C is an outcome measure, controlling high blood pressure is an outcome measure, closing the referral loop is a high priority measure, and statin therapy is a process measure. So if you focus on those four, you will already get bonus points because you're reporting more than one outcome or high priority measure. So that would be 4 of your 6 measures for MIPS that you are already addressing as part of the 1815 work. Zack talked about PCMH. PCMH looks at a large number of items, and most of the time you can cover your quality measures just with the work you're doing with PCMH. You just need to pay a little of attention to what's our MIPS plan going to look like, but you can base it completely off what you're doing with patient-centered medical home. For example, if you are doing annual wellness visits, that wellness visit will cover a large number of prevention measures, which you could also report. So the work that you're doing already captures stuff that you need for MIPS. And I believe, Deb, this is where you wanted to launch another poll. Is that correct? Okay, there we go. So we have 2 questions there, thinking about the priorities for your organization and what topics about that interest you the most. So I'm going to let you work on those poll questions and look at those for just a few seconds. Okay, next slide, please, Deb. Okay. Let's talk next about the category of improvement activities. In the improvement activities category, what has changed for 2020 is that some of the improvement activities, they've gotten rid of a few, they've added some new ones, but the big change is if you are now doing group reporting, 50% of the providers in the practice have to participate in the activity for group reporting. So you can no longer just do an activity for one provider and have that count. You have to have all, you have to have 50% in order to capture that. With needing 40 points, a medium weight activity will give you 10 points. A high weighted activity will give you 20 points. But if you meet a special status, such as small practice or rural, you can double those points. So you really only need, if you're small, you really only need 1 high weighted activity that will cover in order for you to get all the points in that category. Before I talk about alignment, I want to go to the next slide, Deb, and I want to take a look at how we report on those improvement activities. And Deb, I'm not going to go over the results of the poll. I'm going to let you look at that, and you can make a comment on that later if you need, okay?
Okay, thank you.
Yep. Okay, reporting improvement activities. Unlike quality measures, improvement activities are meant to be flexible. They're really meant to be able to adapt to the work that you're already doing in quality improvement on selected topics. They are not specific. They don't necessarily have a numerator and a denominator. They don't have inclusions, exclusions. They're not highly prescribed like we see with the quality measures. And that's intentional. And initially when MIPS came out, that was real uncomfortable for a lot of folks because they were used to those tight boundaries. So instead, what has become important with improvement activities is even though you don't have to report any of that information to CMS, you want to make sure that you're documenting it in case you are audited. And we know audits are possible. Some people have already been audited, and they're going to want to see your documentation for improvement activities. So the best way to kind of get an idea of what you should be documenting for any given improvement activity is to go to the CMS resource library. That's out on the qpp.cms.gov website. And I've got the link there. But in the search box, what you want to type in is the two words data validation. And data validation will bring you up a data validation and audit set of a zip file that has a set of documents in it. And that will walk you through and give you some idea of things that you might want to keep. So for example, you might want to keep minutes of your quality improvement meetings where you're talking about what activities you're doing. You might want to keep a list of patients that you've done the activity with. You're going to want documentation of how you involved more than 50% of the providers in your practice. So really what you're doing is you're building the story of what you did for that activity. And you just create a file, electronically, paper, doesn't matter, it's really your choice. And you put the information in there. CMS can audit you for up to 6 years later. So you want to make sure that you're consistently documenting that year after year so that if somebody leaves or is gone and then you get audited, you can still find your documentation. So that's really the important thing for improvement activities. Okay, let's take a look at a few activities that, that connect to the work that you're doing with 1850.
Karen, I'm going to stop you for just a second because I did see a question come through from Cody in the Q&A box. And just, I know you're going to talk about this, but she's already ahead of us. She said, what's considered a high weight priority? So Cody, I think we'll get to that in the next couple of slides. Also, Mary, will you go ahead and launch the second poll that we have regarding diabetes? Thank you.
Thank you, Deb. That's a perfect question, and we are going to get there. CMS in the that data validation document that I just mentioned, it will tell you in there what's medium and what's high. Also, you can search the activities. CMS has kind of an interactive search tool, and whenever you look at the list of improvement activities, it clearly tells you there what's a medium weight and what's a high weight. And CMS is the one that determines that. I don't know if they have an algorithm or how they do it, but they're the ones that make that determination. So one of the activities I wanted to point out, this is a medium weight activity. And this is the use of specialist reports back to the referring clinician or group to do a closed referral loop. There is also a quality measure that tracks the closed referral loop. So this is an example of something where you can work on a closed referral loop to increase your quality measure scores, and that work that you're doing actually counts as an improvement activity. So that's an example of how you can align not only from a program like PCMH or 1815 to MIPS, but you can also align the categories within MIPS. So the improvement activities that you're doing are focusing on the measures that you're working with. So that's one example. Next slide, please, Deb. Here's another example. This is glycemic management services to work with your diabetics. We know that diabetes A1C is one of those outcome measures that we're very important or very interested in. And so you can set up a glycemic management service program to help you track your diabetic patients, make sure they're getting their labs done, make sure they're getting appointments when they need appointments, and looking at all of that. And as you do that activity and you set that program up, that's a high weighted activity. That counts for your MIPS program. I know that one of the things Deb and I talked about is really how do you document and make sure that you're doing this the way CMS wants you to do it. And I would encourage you to keep samples of those population health reports. Zack talked about using their system to be able to run those reports to identify patients that may have certain needs under PCMH. That's an example of something that you would want to keep in your book of evidence of here's a list of how we identified the patients. And then what was the next step? Did you call them in for an appointment? Did you put a reminder in their chart? You know, what did you do once you knew that these were your diabetic patients that had hemoglobin A1Cs that were too high? How did you address those and what did you do next? Do you have a written procedure on that? Doesn't need to be complicated. It just needs to be guidelines of here's what you're doing consistently. So if you ever get audited, you've got that. Chances are you already have that set up just because that helps you in your practice. You just need to make sure you get a copy of that in your audit book. Okay, let's look at another one. Okay, this next activity, again, this is a high-weighted activity. And this lets you take credit for things you are doing as part of a rural health clinic, as part of, if you're an Indian Health Service clinic or an FQHC clinic, and you're doing improvement activities as part of being one of those groups, that counts. And I didn't put a slide in for it, but being involved with PCMH also counts. I believe you have to have 50% or more of your clinics doing PCMH, and then you can count that as your high-weighted improvement activity. So as you can see here, we're really not adding anything additional on top of what you're already doing, with the exception of making sure you've got this documented in case you need it for an audit. Next slide, please, Deb. Okay, this is a list of all the activities for care coordination. That's what the CC and the ID stands for, is care coordination. And I've also listed the weighting, and you can see here, patient navigator program is high weighting, everything else is medium weighted. And there's a large number of options here that may make sense for what you're doing. I mean, one of them is regular training in care coordination. So if your care coordinators are working to learn more all the time and they're getting training, you may be able to count that one. It's something that you're already doing. Care transition standard operational improvements. Are you updating your policies and procedures on how you're doing care transition? Are you having meetings with people outside your organization to help coordinate things? That may count. Again, it all kind of depends on how you're documenting that and telling the story of why this was an improvement activity for your clinic. CMS wants to see evidence that you just didn't pick something and say, yes, we did it, to check the box, that you were actively, meaningfully doing that activity to improve your services. Next slide. This is a list of the population health management improvement activities. And here's things like regularly reviewing practices in place to target some of your, to target your beneficiaries who need services. Looking at medication management, methodology for longitudinal care management for high-risk patients. If you read the descriptions, you may find that you're already doing a number of those. So there's a long list. Finding an improvement activity, it may be more, the difficult part may be really narrowing down to which one of these are we going to pick, or which two are we going to pick, and how are we going to document on those to make sure we have strong documentation. Okay. Let's move on to the cost connection. Thank you, Deb. Okay, chronic care management is really, it's one of the strongest tools we recommend to people to help improve their cost score in MIPS. The cost category is probably the hardest category to actually see movement that you've really intentionally driven improvement in, because it's kind of secondary. It's not something that you actually get to run the numbers and you have reports that you can look at. It really depends on what your EHR and your business office system give you, as well as what you get from CMS. And CMS does the cost calculation from the claims that you submit for payment. That's how they determine cost. There's a number of factors that go into determining cost. At a very high level, what CMS is doing is they're looking at what are the expected costs for each one of your attributed patients compared to what the actual costs are. And those expected costs are determined from the risk score or the risk calculation based on diagnosis, age, sex, and whether they are dual Medicare, Medicaid eligible. So they look at all those factors to determine by patient what are the expected costs and then what are the actual costs. So we have done some review of that if you need more, but know that when you are doing chronic care management, the first thing is you are providing the plurality of services, meaning you're putting the most E&M codes on that patient. So the patients you're working with should be attributed to you. And that's a good thing because you're working to help coordinate the care, to help manage that chronic disease state and help drive down that cost. So it's one of the best tools that we recommend to folks. What's really important is to make sure that you have accurate coding that goes with that patient, meaning you're coding the diagnosis states that that patient has, and you are addressing those chronic conditions medically, and you are documenting that. I have a link in the slide deck that I came across when I was working on these slides about how CMS is seeing upcoding for patients to get a higher risk score from some clinics out there, and they're able to identify when that's happening, and they're going after them for overcharging Medicare. So you want to make sure that it's accurate. I'm not telling anybody you've got to put extra codes on. You want it to be accurately coded to really portray the state of that patient. And then, of course, active management is really valuable in helping reduce unexpected ER visits, unexpected hospitalizations, as well as really helping to bring that patient to a better state so they don't need higher level cost services. Okay, next slide, please, Deb. Okay, my final thoughts. It is really important to know if any of your providers in your clinic must report MIPS. And Brandy, if you don't mind, can you quick go out to the QPP CMS website and find the participation checker and throw that into the chat box? I didn't get that put in my slide, but there's a really easy way to know if your clinics have to report MIPS. CMS has a little participation checker that you can put in the patient's NPI number or the provider's NPI number, and it'll tell you whether or not they have to report MIPS. So thank you, Brandy. So if any of your providers must report MIPS or they get a penalty, you want to make sure that whoever's in charge of the MIPS program at your facility knows what you are doing with care coordination, and they know what you are doing with 1815, because that supports that MIPS program beautifully. So if you're not already in contact and talking with them, you really want to make sure that that's happening. And the second thing is you want to make sure that everybody in your clinic knows what quality improvement programs you are working on, and make sure they know how they can make that happen. Healthcare is a team effort, and there's some incredible ideas that staff can have and can pull together to make sure that everybody is focused on those quality improvements. whether it's the improvement activity you're doing, whether it's the quality measures that you're looking at. Make sure everybody knows what those are, and even share those with your patients, whether you post the results where the patients can see them, whether they go on the website. Right now, because of the MIPS program and other programs, there is public reporting already happening on your providers. That information is out there on the internet. If you want to dig deep enough, you can find all sorts of information on your providers. So why not toot your own horn about what programs you're working on, what outcomes you're working towards. Share that with the public, share that broadly with your clinic so everybody knows what you are doing. Okay, that's the end of my slides. Deb, any questions for me?
I just wanted to comment that Brandy's got both of those links, the resource link and the participation checker link in the chat box. So please make sure and get those if you need them. If not, you can always follow up with any of us after the webinar, and we'll be happy to help you with those again as well. Brandy, you were monitoring chat, but I don't think I see anything in there either.
Thank you, Deb.
Thank you, Sharon, very much. All right, so we're winding down here. There's just one more update to do. So if you think of any questions for any of our presenters, please let us know, get it into the chat box or raise your hand or come off mute or whatever you need to do. We still have several minutes to do some questions and answers if we need to. The update that we have for you again this month is the fact that we did receive the CMS QIO contract, one of the task orders. So here is the focus of that particular task orders. Some of you may have received information on being one of our recruited clinics or recruited partners. Again, if you have any questions or concerns, or you didn't receive any information, or you haven't heard if your organization has received it, please reach out to us. We'd be happy to help you take care of that as well. Do we have any other questions? Quiet group again today. I would definitely like to thank Zack. Zack, you did a great job presenting. Thank you so much. We're always looking for folks who want to share some success and maybe how the prior work under 1305 or the current work under 1815 or maybe even current improvement work for your MIPS programs is helping your clinics as well. So if you have any ideas for sharing your success, we would love it if you would reach out to us and, you know, volunteer. It's better than being voluntold. So we're always looking for more folks to talk with us. So for the Wyoming group, we will be having a meeting January 16th at 2 o'clock. We will be discussing the CDC Health Systems Scorecard that we will be working with you on for the early part of this year to provide some baseline information. And Brandy, I'm going to go ahead and see if you have anything else to add for us.
I don't. Everything looks good.
All right. Thank you all. I'll go ahead and have us close out the session today. There should be an evaluation that pops up for you. So please take time to tell us how we're doing and how we can help you further. Actually, I will, Mary, if you can help me with this, if we can display those poll results. I was a little bit surprised with some of the information. So there is, okay, the last one, yep. So obviously we need to do some A1C pore control measure validation. That's exciting. We'll get that worked into our education plan and see what we can do to provide that for you as soon as possible. What about the results for the, there you go. Gosh, she's good. And here's cardiovascular. And so basically, I think this ties directly in with our Million Hearts work. So Brandy, this looks like something that we'll be discussing and making a priority in January as well. Thank you all very much for all of the time that you've spent with us today, and we look forward to providing you the technical assistance and support that you need moving forward. Please feel free to reach out to us at any time, and please have happy holidays, everyone.